Recording. All right, so we are recording now, and Tom Derrick from Open Markets is going to kick us off on our learning bite today. So, welcome everyone, and welcome, Tom.
Thanks for having me. This is going to be a lot of fun.
Awesome. Take it away, my friend.
All right. Hi, everybody. Thanks for joining. We've got probably about 20 minutes here, a little fast action hit on the idea, some data around equipment standardization. So, four little pieces of the agenda here. First of all, we've got some proprietary data to share with you all around where health systems are standardized and where they are not, sort of a category by category look. Again, we're focused on equipment here. And then we're going to talk to some of the suppliers. Angelique knows this. I work closely with a lot of equipment suppliers at my company, Open Markets. We see equipment suppliers who excel in areas where they have sole source contracts, certainly pump suppliers, things of that nature. We're going to dive into some nuance on that. And then we're also going to talk about areas where it makes sense to not be standardized, where multi-sourcing equipment leads to better financial outcomes and choice for your clinicians. A lot of this stuff is probably going to feel intuitive to those of you who are at the bedside or those of you who help support clinicians with equipment procurement and getting them the right tools. But at the same point, we're going to get those lessons learned documented there so you can take them and share them with anybody else at the health system. Okay. Now, Angelique, I said 20 minutes there. So
Yes.
we'll see how we do. It's great to go over if we need to, but hey, why not run through it?
No problem. We're ready for you, Tom.
Okay. Quick, by way of background here, I'm Tom Derrick, Senior Vice President and a co-founder of a company called Open Markets. We are software that is, you guessed it, unique and focused on the capital equipment market. We work with a lot of health systems and a lot of suppliers nationwide. Our goal is to help them drive standardization, compliance, capital budgeting, and ultimately cost savings. When it comes down to it, suppliers do well when hospitals are organized and driving compliance too. So the idea is a win-win. All right, Angelique, I do expect you to chime in here from your perspective too, as needed. I didn't tell you I was going to call on you, but one of the things that we have learned in working with health systems nationwide is that there's a lot of inefficiency in the way equipment is brought into the health system. Am I saying anything controversial there, Angelique?
No, it's a big black hole, we'll call it.
Yeah, and there's oftentimes you've got folks at the bedside, clinical team members who aren't aware of what their system agreements are, what any kind of standardization is. They may be working on an anesthesia machine and it's time for a new one. You've got a budget and plan for it. They're looking to just replace what's already there. Or perhaps the sales rep that they met at a trade show or something they found on Google. They don't necessarily know what's on contract, what the preference is. They might think they know, but those change. It can be tough to keep everybody in the loop on what supply chain does on a regular basis. Angelique, quick story about that first one. This was not a customer, but somebody who we're working with to become a customer of ours recently. We said, hey, how many of your clinicians know what's on your GPO contract? We're specifically speaking of equipment. And their response was 90% of our clinicians don't actually know what the GPO is, let alone what's on contract. So certainly there's some inefficiency there when you've got busy clinicians that don't know what's standardized.
Were you talking to Legacy Health there where I work or what? I don't know.
I was not, no.
Okay,
But
it
well,
sounds like us.
yeah. The reality is when you've gone through a standardization effort and you've identified, hey, Baxter's our pump supplier, GE is our ultrasound supplier. When a non-preferred equipment vendor gets in there, it's wasting time. Okay. Nobody needs that. Your clinicians are too important, too busy, too highly paid to be dealing with the wrong suppliers. Lack of visibility to the capital budget costs a waste of time. You see my little spaghetti pie on the right there. That's probably undercomplicated. Really, it takes 10 people 10 months to buy any piece of equipment in a hospital. That's okay as long as you're organized. Okay. All right. Let's focus a little bit more on the challenges that are faced by key stakeholders in equipment procurement. Okay. Three core audiences here. clinicians, finance, supply chain. For the sake of this, I'm including clinical engineering and supply chain as one and the same since they're so tied at the hip from an administrative standpoint. Okay, a lot of this stuff, your clinicians, we covered it there. They've got better things to do than go into Google and figure out what anesthesia machine is on contract. Finance, I don't know if we have any finance folks in the audience. They don't necessarily tend to care when it comes down to it who the standard provider is. They just want to know that there's enforcement of contracts and that you're getting stuff at the right price in an accurate and efficient way. So for finance, if they don't have visibility to the price that you've set in a contract status with the right suppliers, that causes some frustration and can often end up with delays and overpayments. Supply chain. Okay, Angelique, supply chain 101 is never enough visibility to what's coming in all things capital.
True.
Am I wrong?
You're
Okay.
true.
Okay. When it comes to standardization, what we particularly see there is if someone gets, 80 yards down the field with the wrong supplier, supply chain doesn't know about it, the amount of time and cost overruns just start to balloon. So for supply
Yeah.
chain, the challenge is not having enough visibility leads to poor outcomes.
Yeah, Tom, what we're always doing over here is all of a sudden it's a fire drill. Oh my gosh, the vendor just told us it's end of life, end of service. And now what? We're forced into an RFP for $2 million of equipment, which we never budgeted, and it's a firestorm.
Yeah. And the unfortunate thing is those vendors may have made an attempt, they may have checked the box to tell you, their customer, that their equipment was end of life. But how many emails a day do you get, Angelique?
Almost 400.
Is that right? Oh my
Yes,
God. Okay. All right. So one of those 400 emails was the supplier telling you that a product you bought 8 years ago was going to be end of life in a year.
probably.
You can't, you're never going to keep up. You need scalable, health systems need scalable solutions so that people have visibility to what is on contract, what's their standard, when they're going to expire. That's what creates visibility across all three of your key lines here.
Yeah.
All right. We could talk pain points all day. Let's not do that. Let's get to something a little bit more fun. So I want to start breaking into some proprietary data. Quick background here at Open Markets, our philosophy, what we have learned by working with health systems, is that centralizing your data leads to standardization, aggregation, and better contracting. Standardization has clinical and financial benefits. Aggregation has financial benefits, and better contracting saves you time and money. Okay. I don't think I'm saying anything controversial there, am I? Okay.
All good.
All right. Now, here's a little bit of a question, kind of a leading question for you here, Angelique, but how are health systems doing at centralizing their capital data? I think you just told us. It can be hard. Okay. Some organizations do it better than others. I don't want to say preach, that doesn't sound good, but what we see as best practice here is that it can be seen in this centralized workflow on the screen now. Sorry, it's late. It's 6:30 on the East Coast, 5:30 on the West. Sorry to bring a workflow to the table here. But if you think about capital in 4 front-end steps, identifying your research options, quoting and working with the vendors, going through your financial approvals, and then ultimately purchasing it, you touch on those 3 key constituencies we covered earlier: clinicians, finance, supply chain. But also I want to throw value analysis in here because value analysis clearly has an important role in setting standardization. Let me walk you through this centralized workflow because it's going to lead to the standardized data that's coming. Okay. When an end user in a hospital needs a piece of equipment, the very first thing that we should be teaching them is where they go to find out what their contract standards and preferences are. At a lot of health systems today, that's a list that's on Joe's desk in biomed. Okay. And it's a list that may or may not be up to date. Okay. You can put that into a catalog. You can build something. You can have something. You can work with companies to have a dynamic repository of this. If your clinical end users go into the GPO, they can see their, the GPO portal, they can find their GPO contracts there. Or they call Angelique at Legacy and say, hey, which anesthesia machine should we be budgeting for? So that's email number 401, Angelique.
Yes, yes,
Now,
darn it.
of course, what we think is best practice here is that if you don't have a standard piece of equipment, it should go to value analysis. Now, you don't always have time to throw something through a full value analysis process. I understand that might be an abbreviated process, but if it passes value analysis, great. Okay. Then you're really bringing in the vendor to get those quotes, get those final proposals, get the configuration understood. From there, it goes on to capital budgeting, and then ultimately to purchasing in the ERP. There is a color scheme here that matters. You think about the 3 dark blue boxes. There are capital platforms out there that control all of that to help you get centralized in the front end. Doing that creates centralized data. Okay. The
So
customers we work with, please.
real quick, Tom. At Legacy, we try to pre-plan our capital budget. So we, in the fall, write out this long list
Yes.
of all the things that we want to buy, right?
Mhm.
And or we need to buy because maybe we know some things ahead of time when end of life, end of service is. And we try to do this pre-planning of capital, and then they give us a big bucket of $100 million and
Yeah.
say, these are all the things that are approved. Now, also, so I may have capital budgeting approved before, like at the front end, when an end user needs a piece of equipment.
So if we were
This right
drawing that in
here,
there,
yeah,
that's going to be, yeah, that's all got to go through capital budgeting too.
yep, it
So
does.
that's where really your pre-planning from supply chain and clinical engineering are bringing what's typically those fleet items
Yep,
that come in as opposed to the items that come organically up from the floor.
yep.
Both happen.
So then at Legacy, what we have is like called a break fix capital budget at
Yeah.
each site, in hopes to catch like these fire things, and then anything like I think that their break fix is like I don't know 300 $400,000 max per site. And I mean if you got something big that breaks in the middle of the year, good luck to you. You're giving up your new roof or your new furnace or your new carpeting or your new west wing. So yeah, it's
It's
fun.
going to happen. It does happen. Ultimately, everything goes through a budgetary process. That's the front end of capital. You know, is the way, if you're able to have if your biomed team has their data organized in their CMMS system really well, then you're going to have data to be able to do better replacement planning. Of course, that only picks up part of your capital spend every year. So the reality is, you need all of your requests, the stuff that comes from your clinicians and the stuff that comes from biomed and clinical engineering pre-planning
Yeah,
together.
for sure. And any suppliers on the phone, I just want you to know health systems are not purposely trying to say no to your newest, greatest thing. We want the new technology,
Yeah.
but we don't have the budget for it usually. And it's got to come into that planning cycle. And maybe next year we can get it on our, I call Santa's wish list, to bring in your latest, greatest technology. But I mean, yes, I would love to get it, and all my doctors want it, but I just can't afford it, right?
When,
Especially in today's economy.
when I talk to suppliers without providers on the phone, Angelique, we always have this moment of bonding over, selling to hospitals, it's a real pain in the butt because, like you said, yes, budgets take extended periods of time and things do have to be planned. 10 months for 10 people to buy an MRI. That's just the nature of the beast. Okay. Um, Things do go faster when you have standardization. If you're just replenishing a few items of the fleet, it doesn't take that long. Um, Across the open markets portfolio of customers, this is data actually, Angelique, we haven't shared publicly before. So what our team did is they went and they understood the portfolios of equipment across our customers. So we track 717 different categories of equipment. Not every category is the same. Okay. One category is point of care ultrasounds. Another is bariatric recliners. Okay. But if you think about the categories, just by a category, 42% of categories are traditionally sole sourced by health systems. 29% are dual sourced, and 29% are what we call multi-source, where there's three or more vendors per IDN. Does that make sense? Okay.
That makes sense.
Now,
Yep.
certainly, is this what you should be striving for as in a health system? It might be. And we could break that down even closer on a sort of an IDN by IDN basis. But what we have seen is this gives you the nice mix of sole source equipment, which you find most commonly to be these categories: beds, monitors, PCA pumps, stretchers. Intuitive, right? Okay.
Hmm.
How many PCA pumps do you want your nurses trained on? One. Okay. Are stretchers cheaper when you're buying one model or 10? It's one, because you can get fleet pricing, aggregation pricing. That's typically stuff that's done in a fleet pattern. Uh, what we what we have also found that I thought was really interesting in the data is the presence of specialty and niche equipment being highly standardized. Some of that is because there's just not as many suppliers, for bariatric beds and bariatric stretchers, but also for specialty imaging equipment. Um, one category that we track is MRI safe pumps. There's actually just one vendor that makes them. So everybody is by default standardized to that one. It's those items that have a high clinical impact that
That
tend to be
makes sense.
standard.
That makes sense. Tom, I keep thinking about, unfortunately, those health systems out there that are not standardized in many categories. You also are not standardized in your service then, right? So your service agreements, you've
Totally.
got multiple, and or your clinical engineering biomed teams are having to fill in the gap of that. And that's very hard for those teams to be managing service if you are not standardized on some of those categories.
And I wonder, actually, to take that a roll further, like that's not just an increase in your service contract cost, but I mean, how many more bodies does it take within the hospital?
Yeah.
So many teams now, it's reduce headcount, certainly not add. But if you have to manage four different types of monitors, how many more people does that take?
Yeah. Good point.
Okay, so let's talk about the suppliers that fit into those categories you saw on the last page. Across our portfolio of health systems, the number one supplier that had the most sole source categories was GE Healthcare. Certainly, big portfolio plays a role there. Same with Baxter. I don't think it surprises anybody that Stryker is an organization that thrives in sole source contracts and categories. The, the so what here, from our perspective, is that as a supply chain or a clinical leader here, these are the companies to talk to when you're driving standardization initiatives. Like we see within the data areas where GE is partnering with health systems to drive fleet replacements, to drive better pricing, aggregation, um, and really partnership. Um, it's great to see. I think what might be interesting to some of you, though, is to notice the two distributors on there. So you've got Medline and then, of course, Thermo. So when I say sole source supplier there, a great story I loved out of Bon Secours Mercy Health. I hope it's okay I tell this. Uh, years
Sure.
ago, Dan Hurry, who's the smart, personable chief supply chain officer over at Bon Secours Mercy Health, they went in and became a Medline Prime supplier. And his whole goal was to take all minor equipment and shift it from four different, maybe even five different distributors, all to Medline. And their compliance contracts built around it. Can you make sure that people are only buying wheelchairs from Medline? Um, they added some technology and they pulled it off. And they hit really tough compliance contracts for buying minor medical equipment like IV poles and wheelchairs and scales. So you can do standardization in those areas. You have to do it with the distributor rather than the OEM, though. Okay, now Bon Secours is a little bit of an exception. What our data does tell us, though, is that there are a lot of primarily multi-source equipment categories. Um, Again, I think this is pretty intuitive to a lot of folks here, but it's those more commoditized categories: food service equipment, rehab equipment, furniture, IT, and exam lights. I mean, I wonder, not to, I should have prepped you for this, Angelique, but across legacy health, how many different vendors or manufacturers of exam lights do you think there are? You
Oh
know?
yeah, quite a bit. But it also
Yeah,
kind of depends on your threshold for minor equipment versus capital. So I
totally.
think industry standard usually is 5 grand. But if you've
It
lowered
is.
that, or if you have a lower dollar amount and some of those other strange things are fitting into capital that really should have been minor equipment, it kind of
Yeah,
gets weird. Yeah.
it sure does. So our we have some customers that are constantly driving competition around their multi-source equipment categories. Creating a scalable way that says, "Hey, I need to buy $25,000 worth of rehab equipment. Let's go ahead. There's more than one place to buy this from. There's more than one manufacturer, and there's more than one products that meet clinical acceptability. Press a button, get quotes from all of them at the same time. Really helps you to lower your pricing, and candidly keep everybody at the health system just as happy. Not to diminish food service because it is 5:30 here in Chicago, and I got to make dinner when we're off of here. But who cares what brand of toaster it is when it comes down to it, as long as the bread's hot. Um, okay, let's round it up. Angelique, I feel like you kind of got to at least one of these lessons learned already. But I'm sorry to those of you who are, watching for the eye chart. A few too many words on the slide, but the 5 key lessons here on standardization. Number one is that it's achievable but uneven. Okay. And what I mean by that is that you've got certain categories that make more sense for your health system to be standardized on, and certain categories where it may make sense for your health system to be multi-source or dual sourced on. And if you're not sure which categories you should be seeking standardization in, come find me. We've got industry benchmarks on this that can be shared. Um, don't reinvent the wheel. Certainly, your clinicians locally there can provide some insight, but go see what everybody else is doing. That can help determine what the next 2, 3, 4, 5 categories for standardization should be in your equipment fleet. That gets to number two. Look at your own fragmentation. Okay. Do health systems, do you even know where you're standardized? You might think you do, but are you able to look at the data? Are you able to talk to your clinicians and find out, hey, we've always been dual source for this category? Does that add a training burden? Does that add an extra service contract? Gather that data the best you can to look at your own fragmentation. Okay, going along with the theme here, hit those high impact categories. I love the service contract idea, Angelique. Um, if you're able to find out how many service contracts you've got per category, great. Okay, that can be a high impact category. I mean, service is not cheap for a lot of these big pieces of equipment. But focus on the areas where it creates safety, a better workflow, and lowers the cost. Uh, Lastly, the last two here, benchmark against your peers. Okay. A lot of this data is not really available publicly because equipment standardization is just, it's maybe not as sexy as other areas of the supply chain, Angelique, but they do exist. Again, call me if you need them. Uh, and then lastly, really my favorite thing to watch is when suppliers and providers partner together to do long-term win-win compliance and safe and equipment safety agreements. It's cool to see that when we had a front row seat to watching Medline and Bon Secours Mercy Health work together, and Bon Secours works great with GE too. Hope it's okay. I'm telling these stories. Um, the the impact on patient care is there because your clinicians are having a consistent fleet, and certainly the impact on costs are there, and the suppliers are happy as they can be to have a long-term partnership.
Love it. Love it. Well, Tom, I thought you were maybe going to train us on all about asset management and how to stop hospitals moving one patient monitor to another hospital, and how all millions of dollars of lost capital a year in a health system. What happened here?
That is session
That's your
number
next step.
two. Yeah,
That's your
that is
phase
session.
two.
I yeah, it's just invest in a lot of air tags, and you're usually in a pretty good place.
Oh my gosh, I love it.
Um, well, Angelique, any questions from you?
Yeah, other than my asset management, because that is a whole nother learning bite that we need to dive
That is a
into.
fun one. That is a fun one. I'd be happy to. Really,
This
when it
has
comes to
been,
I just one small point on asset
yeah,
management.
yeah.
The key to that is how well your clinical engineering team documents their data. So
Yes.
you've got plenty of clinical engineering teams that are mixed, some outsourced, some insourced. Um, there are probably 20 different pieces of clinical engineering software, CMMS systems. They all do documentation a little bit differently. So if your team is able to input data consistently on the age and quality of their fleet, then you can do some cool things. If they can't, then you want to try and fix that first before you can start diving into an asset-based replacement strategy.
Oh, wow. Okay. Super huge because Legacy's at that point right now. So thank you for that
Okay.
advice.
I will say the one thing is when you think about planning from the front end capital strategy, having a united, visible, centralized capital budget, that captures 100% of it.
Yeah. Yeah, for sure. Well, and we're trying to at Legacy try to put together a 5-year, 10-year plan.
Yeah,
Because I mean, at some point in time, I think we all need it. It's
you
just
do.
we're not there yet. We're not there
You
yet,
do.
right?
You do.
Yeah. I see Kalash had put in there. I think it also helps staff who float between departments and hospitals to be familiar with the products and the equipment. Because
Oh,
true to that point, even if you jump from one hospital to another just to work and they have different equipment, oh my gosh, for a clinician, that's a even almost a nightmare if you're not standardized too.
That's a hard yes from this nurse.
Thanks, Heidi. I love it. I love it. Any questions for Tom or
Angelique,
comments?
thank you. I just want to leave a comment. This is Heidi, and certainly with my experience in from the GPO and distributor side, as well as being a clinician, Tom, what I really appreciated is how you laid everything out, and really showing what the value is on standardizing, because to your point, even from hospital to hospital, and I think part of the frustration from the clinical side is we just don't have the bandwidth to understand things from the contracting side, and then you throw in a GPO, like that's all we need, right? Or more
I know.
acronyms. And so I think it's part of the value that supply chain brings to the table, from the clinical side, is to really help us manage the standardization, so that when we do float to that other department, we're not freaked out saying, oh my gosh, I know this is, this category of product, but boy, it looks different. The bells and whistles aren't familiar to me. So I think when we really start looking at how does all this impact patient care, I think it's such a huge positive, and I think it's something that we don't talk enough about.
Love it.
Yeah.
Well
Capital is a
said.
stepchild.
Well said.
It's an
Heidi, I
afterthought.
think what we hear so commonly is just tell me what my standards are. Tell me what my preferences are and pick one. We'll adjust, we'll adopt, we'll tell you what to pick, but just have it.
Amen.
I love it. Anyone else have any questions for Tom? You can ask him anything, even outside of supply chain healthcare questions. Oh my goodness, look, they're quiet. Well, Tom, I'm going to put in a shameless plug for you. I don't allow any of my guest speakers to sell on my Learning Bites because it's all about education. But if you guys at least even want to do a demo with Tom, please send him an email or shoot him a text there and say, hey, at least just let's do a demo and I want to see what you have going on here. But Tom, I thank you for coming and educating us
Thank
because
you.
this education is so important.
Angelique, we love what you're doing. It's important. and keep it up, whatever we can do to help.
Sounds good. All right, everyone. As usual, I always send the recording out afterwards, along with the PowerPoint. And then, of course, Tom's massive action checklist for you to go do and find value tomorrow in your capital planning. So, thank you, everybody. Good to see you. Thank you,
Thanks,
Tom.
everyone. Take
All
care.
right. Bye, everyone.